So today our topic of discussion is bilirubin metabolism and classification of jaundice. দেরি কেন তোদের? মেয়েরা তো আগে চলে আসে রে। So what is jaundice? How can a physician confirm clinically that there is a suspected case of jaundice? First, the definition of jaundice. What is it? The definition of jaundice? Anybody? Yellowish discoloration of skin and mucous membrane. Okay. In adults, the normal reference range of total bilirubin is nearly 1.5 up to 2 milligram per dl. So after this cutoff or this value, a clinician usually identify icterus or jaundice. Jaundice is the term, pathological term, and icterus is the clinical term. So a physician can suspect clinically icterus whenever the adult patient came to him with a bilirubin level exceeding more than 1.5 to 2 milligram per dl. Okay. So what are the sites to be checked for confirming a case of icterus or jaundice? That is upper sclera, skin mucous membrane, and under surface of the tongue. Do you have clinics posting till now? So the medicine faculty will show you the places of the possible sites to check about icterus. Those are upper sclera, skin and mucous membrane, and under surface of the tongue. And whole of this clinical examination should be done under natural light or under sunlight. So ideally it should be, because no color interference should get along with the interpretation or result. Just like Sally's hemoglobinometer should be done in daylight. So these are called sites of the icterus. Now, jaundice arises from the increase of bilirubin in serum. So increase in the total bilirubin in serum leads us a clinical condition called jaundice. So first we have to know in brief, that is the possible mechanism and possible ways of bilirubin metabolism from its production. So what is bilirubin? I told you earlier, bilirubin is a breakdown product of heme. So the RBC that contains the heme and globin part, the heme or protoporphyrin part or the metal part is finally degraded to bilirubin. From heme to bilirubin, there are few steps, like first, from the dead RBCs, production of heme. So heme is a breakdown product, okay? Now, under the action of a certain enzyme called heme oxygenase, okay? So under influence of these enzyme, heme is converted to the precursor molecule of bilirubin known as biliverdin. Very good. So these biliverdin undergo another set of enzymatic reaction with the help of the enzyme biliverdin reductase. And finally, this biliverdin is converted to bilirubin. This is the enzyme. Mohita, chop gulo bodo durbol re bhai. So, this is the production of bilirubin, but this bilirubin has not even entered to liver. So, our metabolic factory, that is liver, now will come to action. How? এটা মুছে দিচ্ছি, হাতের লেখাটা বড় তো, বোর্ডটা ঢেকে যাচ্ছে বারে বারে, মুছতে হবে। So bilirubin metabolism করতে গেলে একটা আমরা লিভার রাখি, metabolic factory liver. Okay, now gut, and what is this? Kidney. So what we have got? The newly formed bilirubin. Now this bilirubin will come to liver for its uptake and conjugation. So liver is the production site of conjugated bilirubin. So conjugation is there with help of the enzyme UDP glucouronil transferase. So a glucouronil group will be added to the bilirubin molecule. First mono one group, next diglucouronide, finally 2-glucouronil group will be transferred by UDP glucouronil transferase. So after the conjugation, this conjugated bilirubin has a route of exit through intrahepatic duct, common hepatic duct, and common bile duct after getting tributaries from cystic duct. Okay, so this conjugated bilirubin or direct bilirubin will enter to the gut and converted by enzyme action of bacterial protease. Okay, so this enzyme bacterial protease splits the conjugated bilirubin in two parts. The major part is stercobilin and the minor part is urobilinogen. So the main thing, the major thing will be stercobilin that will eventually go to feces, and the minor portion is urobilin or urobilinogen. So this urobilin will mostly taken up by the liver with help of portal circulation, enterohepatic circulation. Liver has dual blood supply from the knowledge of anatomy. One is systemic supply, another is portal supply. Right? So this urobilin is mostly taken up by liver. Okay? And the very minor portion will go to kidney and eventually be excreted through urine. So this is the complete bilirubin metabolism. Okay, do you have any question? Anything? Mostly এটা জানি সেটা ফিজিওলজিতে পড়িয়েছে তাই তো bilirubin metabolism. So mostly this is the metabolism, that the bilirubin produced before liver, bilirubin is conjugated within liver, bilirubin after conjugation, conjugated bilirubin that get incorporated into bile and goes to gut through common bile duct to second part of the duodenum with a window of named as ampulla of butter, and after reaching the gut it will be split into two portions, stercobilin and urobilin. Stercobilin will go to mucus or fecal matter. Urobilin mostly reuptake by liver with help of portal circulation, and the minor part, very less part, will be excreted through urine and kidney. This is all about bilirubin metabolism in short. So this is the concept. Now coming to the jaundice. So etiology, pathology and classification of jaundice in a single chart. Okay. There are how many types of jaundice? Huh? 3 types. Please say the types. Name the types. Key types? Pre-hepatic. Pre-hepatic or hemolytic. তাই তো? তারপরে hepatic. Then post-hepatic or obstructive. তাহলে this is the main classification of jaundice. So at the level of production of bilirubin before entering to the liver, pre-hepatic. Next, at the conjugation level within liver, whether due to machinery failure, due to degeneration or necrosis of hepatocytes, or due to transport or logistic failure, due to obstruction in the descending bile outflow. Okay? And next is the final or the surgical jaundice is called post-hepatic jaundice or cholestatic jaundice. So pre-hepatic, other name is hemolytic. So it is quite evident that at the production level, if the production of bilirubin exceeds than that of our conjugation and excretion and metabolism, then there is increase in total bilirubin as well as unconjugated bilirubin in serum. Okay? So the common cause of pre-hepatic jaundices are mostly the hemolytic causes, hemoglobinopathies, autoantibody, hemolytic anemias. তাহলে কনসেপ্ট থেকে 2-3টে নাম যাতে বেরোতে পারে, চার্ট মুখস্থ করার দরকার নেই, যদি কনসেপ্ট ক্লিয়ার থাকে 3-4টে নাম এমনি বেরোবে। ঠিক আছে? তাহলে হিমোলিটিক জন্ডিস মোস্টলি কি কি হচ্ছে? হিমোগ্লোবিনোপ্যাথি, থ্যালাসেমিয়া, drugs. Why drugs are involved? How? Because they decrease the uptake of the bilirubin. They compete for the same molecule of the liver. So before conjugation, the bilirubin level will increase. Next, autoimmune hemolytic anemia. Because of the presence of cold antibody, okay, or warm antibody, intravascular hemolysis occur and the dead RBC production causes excessive production of bilirubin. Okay, autoimmune hemolytic anemia. So, have you encountered the term of carnicterous physiological jaundice? So, those are the examples of pre-hepatic jaundice, unconjugated hyperbilirubinemia, or conjugated hyperbilirubinemia, or obstructive jaundice. Pre-hepatic, yes, pre-hepatic. Tale physiological jaundice, overproduction of bilirubin. Before conjugation capacity of the liver will be very less in newborn. So the excess erythropoiesis, excess extramedullary erythropoiesis will lead to excessive production of bilirubin beyond its capacity for conjugation and uptake by liver. So there is an increase of unconjugated bilirubin in serum and the baby will look like yellow in physiological jaundice. Okay. Hemolytic disease of newborn, same, but there is hemolysis. There is RBC death and destruction, and the senescent RBC or dying RBC will release bilirubin to blood. Okay, hemolytic disease of newborn. Now next we'll come to hepatic causes. Okay, so hepatic causes, I told you earlier, hepatic causes of jaundice may be due to two failures. Either there is a machinery failures due to loss, damage, degeneration, necrosis of hepatocytes, okay, or the logistic or transport failure due to some abnormality that interfere the intrahepatic biliary radical. Okay, okay, intrahepatic biliary radical. If the cholestasis is intrahepatic within the liver, the insult within the liver, the biliary radicals, the biliary twigs, intrahepatic biliary channels, then there will be jaundice. That jaundice is of hepatic type, but that jaundice is the obstruction within the liver, not beyond it. So, hepatic causes of jaundice. So, hepatic causes of jaundice will show the increase of serum bilirubin level of which type? Both unconjugated and conjugated. So, if the degeneration of the hepatocytes due to some virus, some toxin, then hepatitis occurs and the degenerated hepatocytes won't suffice its machinery for conjugation of the bilirubin by providing glucouranosyl transferase enzyme delivery. Okay, তাহলে causes are, common causes are hepatitis, viral hepatitis, also drugs. Those are interfere with cytochrome P450 metabolism. They compete with the same molecule for conjugation and metabolism. So conjugation will be difficult to carry out. So these are causes of hepatic causes of jaundice. Okay. Up to this clear? বুঝতে পারছি সবাই? Any question up to this thing? Now next is post-hepatic. So there is entirely transport failure, logistic failure, post-hepatic jaundice, cholestatic jaundice, obstructive jaundice, surgical jaundice, all terms are synonymous. Okay. So here after conjugation of the bilirubin, so production level checked, no problem. Conjugation level checked, no problem. Now the problem lies within the transportation level, logistic level. So bilirubin after conjugated, this supposedly to come within the biliary radicle, within the liver, then finally come out from the liver through common hepatic duct by making confluence of right hepatic duct and left hepatic duct. This common hepatic duct will get a tributary from the cystic duct and will be finally termed as common bile duct, and this common bile duct through ampulla of Vater is destined to drain its contents to the second part of duodenum. Okay? Okay? So up to common hepatic duct to the ampulla of Vater in the second part of the duodenum, any tumor, any stone or any pathology that will cause the obstructive jaundice diseases. So anything, any insult starting from the common hepatic duct to the ampulla of Vater, this road wherever blocked, the result will be obstructive jaundice, the result will be surgical jaundice, the result will be cholestatic jaundice, and the result primarily involve bilirubin, total bilirubin increase with which portion it will be increased? The conjugated bilirubin part or direct bilirubin part, more than 50%. In LFT, we need to check whether the direct bilirubin will cross more than 85%, more than 50%. But we can see that hepatic jaundice, the direct bilirubin percentage will be less than equal to 50%. And direct bilirubin percentage in post-hepatic jaundice of percentage of total bilirubin nearly 50% to 85%. So direct bilirubin portion is increased. So the causes are from the concept, no need to mug up and memorize long chart. So any tumor, common, first common thing happens commonly. Okay, this is the essence of practice. Common thing happens commonly. So the most common cause in our Indian country is gallstone. Okay, cholelithiasis. Next, stone in gallbladder, stone in cystic duct, choledocholithiasis. Next, a congenital cause, congenital biliary atresia. Very unfortunate for the newborn kid. Surgery te esab porbi tora, not porbi, porbi. Bailey Love'er boi porbi. কতগুলো টাইপস হয় অ্যাট্রেসিয়ার। Congenital biliary atresia. Next, tumor of bile duct. Next, tumor of ampulla of Vater. কি বললি? And finally, the tumor of, very common in old age, extreme of age, that is the tumor of head of the pancreas. So head of the pancreas is just adjacent of ampulla of Vater of the second part of the duodenum. So any insult of the head of the pancreas tumor, it causes pressure effect, it causes compressive effect to the confluence of common bile duct to ampulla of Vater, then the bile secretion and bile transportation to the gut will be compromised. Then there will be occurrence of obstructive jaundice or post-hepatic jaundice. Okay, concept clear up to this classification? Now, etiopathogenesis is over, classification of diseases will be over. Now, few clinical and laboratory part. And finally, I will conclude with 2 to 3 problem question. Okay. So, blood parameters ki hai? So, in pre-hepatic jaundice, post-hepatic jaundice and hepatic jaundice, significant change in blood, associated change in urine, associated stain, change in stool. So, hematology and clinical pathology, if the interpretation of results will be dealt carefully and with concept, then it will be very easy to differentiate from the report and the clinical symptoms itself the which type of jaundice is patient undergoing. Okay. So coming to the pre-hepatic hemolytic jaundice, what are the possible laboratory findings? Low hemoglobin, taito. Next, direct bilirubin will be less, but total serum bilirubin will be more, and unconjugated bilirubin proportion will be more. Okay? Got it? But LFT, liver function test, will be not harmed to that extent. Normal mostly. Liver function test will be normal. Why? Because the insult is production level. At production level, huge production, but less conjugation. Huge production beyond the conjugation capacity, not less conjugation, beyond the conjugation capacity. So, low hemoglobin due to hemolysis, total serum bilirubin will be increased, and the unconjugated bilirubin portion of that total bilirubin will be increased as well. Liver function test normal. Okay. Now urine. So urine, presence of urobilinogen will be present in pre-hepatic jaundice, but bile pigment is absent in pre-hepatic jaundice or hemolytic jaundice. Okay, so urobilinogen is present, bile pigment is absent in urine findings. Stool, presence of stercobilin. Present. So stool will be normal colored. The yellowish color of stool will be attributed to the presence of stercobilin that will come to the exterior oxygen exposure. After getting oxygen exposure with oxidized to stercobilinogen, that is the yellow color product. But stercobilin is the main product. Stercobilin is present. So urine urobilinogen is present, but bile pigment or bile salt will be absent. Okay. Next, coming to the post-hepatic, because this is one extreme, like North Pole, this is South Pole. So blood findings will be hemoglobin may be normal, total serum bilirubin will be increased, direct bilirubin or conjugated bilirubin will be heavily increased, and liver function test is deranged, not normal. তাহলে কি কি রেজড হতে পারে লিভার ফাংশন টেস্ট? তোদের ডিওপি সেশন হয়েছে লিভার ফাংশন টেস্ট ইন্টারপ্রিটেশন সেরোলজি হয়েছে তো? হ্যাঁ, হয়নি? কেন হয়নি? আমি তো পড়াই। আচ্ছা ঠিক আছে, হবে। সো লিভার ফাংশন টেস্ট টোটাল বিলিরুবিন বেশি, আর কি এটা বেশি হয়? এএলপি মানে কি? অ্যালকালাইন ফসফেটেজ will be increased to many folds. Okay, urine finding, urobilinogen is absent, but bile pigment or bile salt will be present. So the urine will be, patient will come to you with the complaint of, Dr. Babu, amar urine ta kirokom hocche? Mustard color, deep yellow. Okay, so presence of bile salt and bile pigment is attributed to the mustard coloration of, deep yellow coloration of urine. আর স্টুলে কি থাকবে? সেই একই পেশেন্ট স্টুল কিরকম হবে বলবে? ক্লে কালার্ড উইদাউট এনি yellowish tinge. So there is profound absence of stercobilin. So there is profound absence of stercobilin. Okay, so pre-hepatic jaundice is a one pole, post-hepatic or cholestatic jaundice is on another pole, and here is the mixture of both these parameters to some extent. Okay, so this is the middle of the two spectrum of post-hepatic jaundice and pre-hepatic jaundice. So the middle man is hepatic jaundice. So the blood parameters will be likely increase in total serum bilirubin. Okay, both direct bilirubin as well as unconjugated bilirubin will be more. Okay, and LFT will be deranged. Why? Other enzymes of, কি হলো ওখানে? পড়ে গেলি নাকি কেউ? LFT, তাহলে LFT তে কোন কোন এনজাইমস আমার চেঞ্জ হবে? ALP, AST, এগুলো, তাই তো? অ্যালানিন ট্রান্সামিনেজ, অ্যাসপার্টেট ট্রান্সামিনেজ, এই এনজাইমগুলো চেঞ্জ হবে টু মেনি ফোল্ডস। ওকে, তাহলে ব্লাডে কি হবে? ইনক্রিজ ALP না, AST আর ALT, অ্যালানিন আর অ্যাসপার্টেট। ALP হচ্ছে অ্যালকালাইন ফসফেটেজ। তাহলে এই এনজাইমগুলো ইনক্রিজ হবে। অ্যালকালাইন ফসফেটেজও বাড়তে পারে, কিন্তু অত বেশি বাড়বে না, not to that much level. So this is the mixture of both two extreme scenarios, both spectrum. Total serum bilirubin, major portion direct bilirubin, but also unconjugated bilirubin will be more. AST, ASP, AST and ALT will be increased. Okay, this is the conditions of hepatic jaundice. Urine may be yellow color to normal color. Stool is yellowish color because presence of stercobilin and presence of urobilinogen both are found or both are evident in hepatic jaundice patients. Okay, তাহলে মেন পার্থক্য হচ্ছে প্রি-হেপাটিক জন্ডিস এন্ড পোস্ট-হেপাটিক জন্ডিস। তাহলে বোঝা গেল সব কি কি বললাম? দুটো স্পেকট্রাম, একটা হেপাটিক জন্ডিস, একটা প্রি-হেপাটিক, একটা হচ্ছে অর হিমোলিটিক, একটা পোস্ট-হেপাটিক অর অবস্ট্রাকটিভ। তাহলে এই দুটো এক্সট্রিমে আমরা ম্যাক্সিমাম রিমার্কেবল চেঞ্জেস দেখতে পারবো। আর মাঝামাঝি যেটা হেপাটিক জন্ডিস, সেইটা হচ্ছে মিক্সচার অফ দোজ টু প্যারামিটারস আমরা দেখতে পারবো। সিরোসিসে কি ধরনের জন্ডিস হবে? অ্যালকোহলিক লিভার ডিজিজ সিরোসিস, hepatic. So the insult will be in the conjugation level, metabolism level. তাহলে সিরোসিসে হবে আমাদের hepatic type of jaundice. ঠিক আছে, তাহলে তোদের এবার কোশ্চেন কিরকম দিতে পারে? What are the possible questions? Possible questions will be with case scenarios. কিরকম case scenarios দিতে পারে? Like a 2 days old newborn baby come to your clinic with deep yellowish discoloration of skin and mucous membrane and entire trunk with extremities. Okay. What are your provisional diagnosis? What are the tests that you execute to confirm your provisional diagnosis or clinical diagnosis? What are the possible mechanism for etiopathogenesis of this disease? And finally, what are the method of therapy or the name of the therapy to treat this disease? Okay. Tale from the history, what is evident? This is a case of physiological jaundice, right? Probably physiological jaundice দেখতে গেলে তাহলে আমাকে কি দেখতে হবে, কি ইনভেস্টিগেশন করব? পরীক্ষা পাশের জন্য তো লিখবি অনেকগুলো, বেসিক কোন দুটো লিখলে পাস করবি সেটা বলি। একটা বিলিরুবিন অর এলএফটি আর একটা হিমোগ্লোবিন। ঠিক আছে, বিলিরুবিন বেশি থাকবে, আনকনজুগেটেড বিলিরুবিন পোর্শন বেশি থাকবে। সো ইন দ্য সিনারিও total serum bilirubin will be increased, unconjugated portion or indirect bilirubin portion will be increased, but in physiological jaundice the hemoglobin won't be less because there is more production, extramedullary hematopoiesis in newborn baby. But if hemoglobin is less, reticulocyte count is high, okay, and there are other features of hemolysis, then you will suspect hemolytic disease of newborn or carnicterus like this. Okay, so the history will be like this. Or in another case, like a male patient with chronic alcohol abuse will come to you with yellowish discoloration of skin and mucous membrane, with deep colored urine, and with huge distension of abdomen, okay, and fine tremor of the hand. Tale what are the clinical diagnosis of your what are the possible etiopathogenesis of this case? What are the symptoms? What are the therapy? তাহলে এটা কেস কি হতে পারে? এটা ক্রনিক অ্যালকোহল অ্যাবিউস, সিরোসিস, তাহলে লিভার সিরোসিস হবে। আর এই কেসটা তোর কাছে যখন এসছে, এটা পেটটা ভুলে গেছে মানে কি হিউজ অ্যাসাইটিস হচ্ছে, তাই তো? হাত কাঁপছে মানে কি ট্রেমর হচ্ছে, মানে হেপাটিক এনসেফালোপ্যাথি আস্তে আস্তে ডেলিভার করছে। তাহলে তার আমি টেস্ট করলে কি কি দেখবো? লিভার ফাংশন টেস্ট করব, এএসটি বেশি থাকবে, এলটি বেশি থাকবে, অ্যালকালাইন ফসফেটেস বেশি থাকতে পারে। যদি অ্যালকোহলিক হিস্ট্রি থাকে তাহলে কি বেশি থাকবে? এক্সক্লুসিভলি গামা গ্লুটামিল ট্রান্সফারেজ জিজিটি, যেটা অ্যালকোহলিক ছাড়া অন্য জায়গায় খুব রেয়ারলি পাওয়া যায়। তাহলে আমি সাপোর্টিং টেস্ট এইটা করব। হিমোগ্লোবিন দেখবো নর্মাল মোটামুটি, ব্লাড ইউরিয়া নাইট্রোজেন বেশি থাকবে ফর ইম্পেন্ডিং চান্সেস অফ হেপাটিক এনসেফালোপ্যাথি। সো দিস আর দ্য ইনভেস্টিগেশনস দ্যাট ইউ মাস্ট read or must write whenever there will be questions to support your diagnosis of clinical diagnosis of cirrhosis. Okay, so these are the tests. Now the therapy will be symptomatic mostly, and the final therapy is liver transplantation. Okay, Next, another case will come to your question, like a old age 75-year-old male patient with weight loss, anorexia and clay colored stool recently visited your clinic. What are the possible ways and your clinical diagnosis? Suspicion এইভাবে কোশ্চেন দিতে পারে। তাহলে ওটা কি কেস আমি দেখব? অবস্ট্রাকটিভ জন্ডিস হতে পারে। প্রভিশনাল ডায়াগনোসিস আমি কি দেখতে পারি? কার্সিনোমা অফ দ্য হেড অফ দ্য প্যানক্রিয়াস বা কার্সিনোমা অফ দ্য হচ্ছে ample of butter or the bile duct, whatever, carcinoma will be there because it is evidenced by anorexia, evidenced by weight loss, vomiting and clay colored stool. So clay colored stool will be direct meaning of insultation of the bile duct, okay? So there is obstruction of the bile duct. So what will be the possible investigation findings? Total serum bilirubin will be increased, direct bilirubin will be increased, ALP or alkaline phosphatase will be heavily increased, okay? USG or CT scan will show a growth compressing the common bile duct or whatever there is inside ample of butter of head of the pancreas, okay? Urine, urobilinogen absent, stercobilin absent in stool, bile pigment, bile salt present in urine. So these are the possible clinical and hematological findings in case of obstructive jaundice, okay? So bilirubin metabolism, classification of jaundice, blood and clinical pathology findings, and finally 2 to 3 model questions I have discussed. Any confusion from any end of this class? Any confusion?